Hello, everyone. My name is Dr. Robin Friedman. I'm a colon and rectal surgeon here at Valley Health. I want to thank you all for coming and listening to this presentation. The presentation is entitled What You Need to Know About Colorectal Cancer. While I'm a surgeon, I see patients in the office for benign conditions. I do surgery, I do colonoscopies to look for cancer, but I'm going to mostly focus on what you can do to prevent yourself, your family members, and your friends from getting colorectal cancer. So my objectives are to do an overview of the incidence of colon and rectal cancer, discuss some risk factors, some that you can control and some that you can't control, screening options that are available. I'm going to emphasize the value of a colonoscopy, and then I'm going to very briefly just touch on some surgical technology. So just some background, colorectal cancer is the second leading cause of cancer-related deaths in the United States. Every year, about 140,000 people in the United States are diagnosed with colorectal cancer, and 52,000 die from it. This affects men slightly at a higher incidence than women, at 4.3% of men and 4.0% of women developing colorectal cancer during their lifetime. Fortunately, the death rate has been steadily declining over the last 20 years, and that's thanks to our screening measures. Current screening guidelines enable us to recognize precancerous lesions, which we refer to as adenomatous polyps, or you might just hear us call them polyps. Screening can prevent the development of colorectal cancer and identify patients who are at risk for developing these polyps at a more frequent rate. So just some very basic anatomy for those of you who are unfamiliar with a digestive tract. You can see in this diagram, you have the stomach, and that's where our food starts to get digested. Then it goes through the small intestine. And the organ we're talking about is the colon and the rectum. So that's that organ that's highlighted here. It starts on the left-hand side of your screen or the right-hand side of your body, and it goes all the way to the right-hand side of the screen or the left side of your body. So all the way from the tip of the appendix down to the anus. And in the colon is kind of like a tubing or a pipe. Our food goes through this pipe, and a lot of the water that we consume and the water from our food is absorbed throughout it. And I just wanted to show this image because it shows a cross section, or if we were to cut the colon up and down. And it shows the layers of the colon. And polyps will form inside of the colon, and that's how we evaluate them through colonoscopy. It's not on the outside, but on the inside of the colon. And then just a reminder, the main function of our colon and our rectum is to absorb water and electrolytes. In addition, it provides a facility to store undigestible material. So if, God forbid, you needed a piece of your colon out, you can survive, you can have normal bowel function. Those patients that unfortunately need all of their colon out, they can still live a healthy life, just bowel function is slightly altered. And I don't mean to get into too much details, but the way that colon and rectal cancer develops is you start with normal cells on that lining of the colon and in the inside of the colon, that cross section that we showed. And those cells can mutate, which means that their DNA gets altered when they replicate, and that can cause polyps. And polyps aren't cancer, but they're precancerous lesions, meaning that they can turn into cancer. And the goal for a colonoscopy is to identify these. If they're left undetected, they can turn into larger cancers. They can have what we call high-risk features or higher risk characteristics to turning into cancer, and then they can turn into actual cancers. I really want to emphasize that most colorectal cancers don't cause any symptoms at all. I frequently meet patients who are a little bit hesitant to undergo a colonoscopy, and they tell me, I've been feeling fine. I go to the bathroom every day. I don't have any blood in my stool. I haven't lost any weight. But usually those symptoms of bleeding, abdominal pain, changes in bowel habits, weight loss, those come with more advanced cancers. And again, going to that cross section of the bowel, it'll show you from the left side of the screen where you see stage 0, that's a polyp. That's something, again, we could detect on colonoscopy and remove through a colonoscopy. And as it gets bigger and bigger, it can turn into a cancer, such as stage 1 cancer, and then stage 2 cancer, which involves more of the bowel wall, and then stage 3 cancer, which spreads to the lymph nodes, which are drainage basins for our immunity cells, and that just suggests the cancer is outside of the original organ that it derives. And then stage 4, where it spreads to other organs such as the liver and the lungs. So I just kind of wanted to give you a brief overview so you'll understand that if we find polyps at stage 0, we can prevent them from turning into all these other stages, which are more difficult to treat and lead to poor outcomes for patients. So what can you do to help prevent colorectal cancer? Well, we have to think about the risk factors. Some of us, unfortunately, are born with risk factors. We may have family members who have a history of polyps or cancers, may have even had a hereditary colorectal cancer syndrome, which makes up a small percentage of patients with colon cancer, but it does exist. These would be syndromes such as familial adenomatous polyposis syndrome or Lynch syndrome. So it's something to be aware of your family history. But some of the factors that we can kind of change, smoking, that the higher risk of colon cancer, eating excess processed meat can also increase your risk, alcohol intake, not eating enough fiber through fruits and vegetables, being overweight or obese, being inactive. So we really emphasize just living a healthy, active life. And then there's other factors that may play a minor role, such as taking aspirin is thought to be protective, statin use, things of that nature. So the best thing you can do is try to always live a healthy lifestyle and know your family history well. So screening tests. Just broad overview of screening tests in general. They're designed to help determine if an asymptomatic patient has an undetectable condition. And it's desirable that these screening tests can catch the disease at a stage in which, if you were to treat it, you can give them a better outcome. Tests should be safe, they should be sensitive, meaning that they can find the vast majority of patients effective, they should be affordable, they should be widely available, and they should address a major public health problem. And then again, we need treatments that are available to help these patients once we do detect an abnormality or a disease state. So when it comes to colorectal cancer prevention, there's a few different types of tests. There's stool-based tests, and these tests can look for things such as blood in the stool. The most basic versions are performed yearly and they're not very sensitive. There's also tests that you may have heard of on TV, such as Cologuard. These are also stool-based tests. It looks for both blood and cancer cells in the stool. It's generally performed every 3 years. It's only reserved for average risk patients. It's not therapeutic, meaning if there's an abnormality, it cannot treat it. And there's a limited sensitivity. And we'll discuss this a little more in detail on the next few slides. And then there's visual exams. So what I can still consider the gold standard is colonoscopy. For average risk patients with no polyps, every 10 years it's performed. And then there's CT colonography, which is a special type of CAT scan or imaging study that can be performed every 5 years. But again, if there's an abnormality with that type of test, you cannot intervene like you can on a colonoscopy. I can't emphasize this enough. Any abnormal test should be followed by a colonoscopy. It doesn't matter if there's blood in the stool, you have a positive Cologuard, all of those tests should be followed by a full colonoscopy. So let's talk a little bit about Cologuard as it's become quite popular. You'll see PCPs or your primary care physicians discussing them with you. You'll see commercials, you'll see pamphlets. So I just wanted to kind of discuss their intended purpose. So they are performed every 3 years at home. You get a kit in the mail and it describes how to perform it. There's also videos online instructing you on how to perform the exam. In order to do it, you need a large stool sample because it is looking for tumor DNA. And the amount of tumor DNA in the stool, if you do have cancer, is pretty low. It combines immunochemical testing and DNA testing, and it looks for different gene mutations. And these gene mutations can be associated with polyps and cancers. This test is only for average risk patients. So average risk means that you have no personal history of colon cancer or polyps. You have no history of inflammatory bowel disease such as Crohn's or ulcerative colitis. You have no family members, no first-degree family members, meaning mom, dad, brother, sister, or even offspring that have any colon polyps or cancers. So it's a limited population. And results should be interpreted with caution because it's not a perfect test. The Cologuard test was studied in a patient population of about 10,000 patients aged 50 years or older who are at average risk of colorectal cancer. Now, I just want to point out that now the screening age for colorectal cancer is 45. At the time of the study, it was 50, and that's why they used this population. Of those patients who had positive Cologuard tests, only 4% of them had cancer. 28% of them had what I would call an advanced adenoma, or an adenoma that's closer to being a cancer. 31% had non-advanced adenomas, meaning polyps that are more benign and once removed, they are completely treated. And then 45% of patients had no adenomas or no polyps at all. So I just want to emphasize again, too, if you have a positive Cologuard and then you do go for a colonoscopy, there's still a 45% chance that there's nothing wrong at all. 13% of the patients in the study without any colorectal cancer or advanced adenomas had received false positives, meaning that they were told that they could have a polyp or a cancer, but they actually didn't have any of those things. And 8% of the patients with cancer received false negative. So in the group of people with cancer, 8% of them were told that they do not have cancer. So going back to colonoscopy, I still think that this is the gold standard or the best test. It allows for us to fully visualize the lumen or the inside of the bowel, as I showed on those previous diagrams. And that allows us to look at the lining to look for any polyps or any cancers or any abnormality whatsoever. At that time, we could typically remove the polyps in their entirety. If they're too large to be safely removed, then you have an appropriate discussion with your physician. Colonoscopy is associated with the major risk reduction in cancer incidence and mortality. Again, because we're taking polyps out before they become cancer. And I'm sure some of you are familiar that the screening guidelines used to state that you should begin screening colonoscopy if you're an average risk patient at age 50. However, the American Cancer Society had updated their recommendations in May of 2018, and many other societies have since updated their recommendations to an age of 45 for average risk patients. They also state that you should continue screening until age 75 or until your life expectancy is about less than 10 years from the date that you visit your physician. And that's because colon and rectal cancers are very slow-growing lesions. So they feel like if you're 75 years old, but unfortunately you have heart failure and you're likely not going to make it till beyond 80, that it's not worth it to even look for any polyps at that point because it's unlikely to affect your longevity. So again, these ages are flexible because if you're in pristine health and you're 85 and you may make it to 100, then if you're suitable, we also do colonoscopies. I love this diagram. This diagram shows the percent of patients per state that have undergone their colorectal screening test. You'll see Massachusetts is doing a stellar job at 76%. New Jersey is at 68%. And this dates back to 2018. So our goal obviously is to hit 100%, but that will certainly take some time. So you may ask, why did they change the screening guideline? Why is it no longer at 50 years that I have to start my screening colonoscopy? Well, they found that 51% increase in incidence between 1994 and 2014, with an increase in mortality of 11% between 1995 and 2015. Interestingly, rectal cancer incidence has doubled between 1991 and 2014 for patients ages 20 to 49, which is very startling because 20 is a very young age to develop rectal cancer. Nobody's quite sure what is driving this increase in prevalence, but there are thought to be some environmental factors at play. Also, there's a similar prevalence of large polyps in patients aged 45 to 50 as there are greater than 50 years. So we feel like if we can catch those patients early, then we can help prevent colorectal cancer. So I just wanted to touch on what does a colonoscopy truly involve for the patient. I know it can sound very intimidating if you haven't experienced one before, you don't have a close family member that has. So I just wanted to kind of go over what I tell patients when I see them in the office. So typically the worst part is the bowel preparation, and that takes place the day before the colonoscopy. For my patients at 4 p.m., I have them start with their bowel preparation. The whole day before, they're on clear liquids, which include Gatorade, Propel, chicken broth, Jell-O, anything that's see-through and doesn't have particles, that's considered a clear liquid. Then at 4 p.m. that day, they take 4 Dolicholax tablets, and again, this is for my patients. And then typically I have them drink 8 glasses of Miralax mixed in with these electrolyte-rich fluids, once again, such as the sports drinks that I mentioned. Typically by about 7 p.m., your bowel movements should be nice and clear, and if they're not, we have you do a backup drink such as magnesium citrate. So it is a lot of trips to the bathroom. It is uncomfortable, but once you're done with that, the rest is easy. You wake up the next day, you just need someone to drive you to and from the examination because you are going to get sedation. The sedation is propofol. It's a very gentle anesthetic. It starts very quickly from when it's administered, and it wears off quickly once we're done with the procedure. But you will have no memory of the procedure whatsoever. You will not feel any pain or discomfort. Once the procedure is done, and it generally takes about 20 minutes, your doctor will meet you in the recovery area and discuss the findings. For my patients, I usually provide a printout with the report and some images to show you that we made it all the way through the colon and how nice your colon clean out was, and just so you can see that you did a good job and that there was no lesions. If there are any lesions, I also take pictures of those, and I take pictures of after I'd remove them and how things look. There's low risks associated with colonoscopies. It's a very safe procedure. Very, very rarely will you have some bleeding afterwards if any polyps are removed, and very rarely, less than 1 in 5,000 patients will have any injury of the colon requiring additional procedures. You can return to your normal activities the following day. You just can't drive within the 24-hour period of getting the anesthetic. So after the procedure, you've talked to your physician, we've discussed findings. Your next colonoscopy will really depend on what was found. Just for example, if you had just one small polyp and it was benign, then you would do a colonoscopy every 5 years if you're an average risk patient. If you're an average risk patient and you had no polyps, then you would have 10 years off till your next examination. But again, this is all varies on the findings. If unfortunately you have a very large polyp that can't be removed during the colonoscopy, or you have findings consistent with a cancer, then you would come and see someone like me, a colorectal surgeon, or some of my partners. And at that time, we would meet in the office and we would talk about things and discuss the next treatment option. And lastly, I just wanted to touch on surgical technology. Over time, our technology has advanced significantly. We no longer always need to do large incisions on your abdomen to do any surgeries that may be required. On the left-hand side of the screen, you'll see what's called laparoscopic surgery, which involves smaller incisions, less postoperative pain, and a lower risk of hernia. On the right side of your screen, you'll see some robotic surgery, and that's something that in my training I had specifically focused in on and did some special training in. It's what we do at Valley Hospital for those who are good candidates for it. And once again, it's associated with smaller incisions, less pain, and a lower risk of hernia. So in summary, colorectal cancer is a common yet preventable disease. Screening colonoscopies save lives and help direct screening protocols for yourself and your family members. You can enter the Fast Track Colonoscopy program at Valley Health online. or you can meet with a colorectal surgeon or a gastroenterologist to discuss the procedure further. Thank you all for tuning in, and if you have any questions, please share them with the group. Thank you.